And what we did was we identified 250 individuals with Parkinson's disease who are followed in community-based movement disorder practices. And these individuals completed self-report inventories on depressive symptoms, and then if they met certain criteria, they went on to have a diagnostic psychiatric interview. And what we show here in this study of 250 individuals with Parkinson's disease who've undergone very comprehensive psychiatric interviews is that about 41% of patients had no depressive disorder, and 39% of patients had a major depressive episode at the time that they were seen. 5% had a non-major depression, and then we had other people with other non-major depressive disturbances that don't really fall into any specific category, and then about 3% with bipolar affective disorder. Of those 97 individuals who had a major depression, we had only 10% of those were actually treated to remission, so they were asymptomatic at the time. Unfortunately, the majority of patients, 90% of those patients with a major depressive episode, were either partially treated or had not been recognized as having had a major depressive episode at all. So about 30% were symptomatic and not treated whatsoever, and another 61% were partially treated. So they were taking antidepressant, but they were continuing to suffer from their major depressive syndrome. And the average duration of the current depressive episode was about 3 years in this sample. So again, it tells us that even though it's well recognized that about half the patients have some sort of clinically significant depressive disturbance, we see that many patients are undertreated or not even recognized as having a depressive episode in actual clinical practice. It's extremely important, however, that we treat these depressive episodes. So I mentioned that 10% of the patients in this community-based sample were treated to remission. And depression remission, we have shown in a separate series, improves physical activities of daily living. These include things like walking, hygiene, ability to speak, eat and feed oneself, and basically carry on your physical activities of daily living that allow you to function independently. And what we see here on the top bar, over time, these are individuals who were followed for 6 years in our longitudinal study of Parkinson's disease at Johns Hopkins. And in the red, you see individuals who have remitted depression. In the green, you see individuals who are not depressed at all. Those are probably better seen as it's really overlapping the remitted depression line. And on this scale, which is a measure of activities of daily living, the Northwestern Disability Scale, that with a higher score represents better function, and a lower score represents more impairment on your activities of daily living. And what you see at any given time point over the years that they're followed, they're seen at 0 year, at baseline, 2 years, 4 years, and 6 years. At any given time point, a patient might be depressed or it might be in remission. And when you're in remission, you have fewer impairment or less impairment in terms of your activities of daily living. And this is a significant difference at any given time point. So treating depression to remission improves your activities of daily living significantly. What we also showed was that over time, that the motor deficits and the depressive symptoms also predict your degree of physical instrumental activities of daily living. So instrumental activities of daily living are those kinds of functions that allow you to live independently in the community, such as being able to shop or prepare food, housekeeping, laundry, and transportation. So not only was it the motor deficits that predicted your physical instrumental activities of daily living, but it was also depressive symptoms. We also looked at other motor features, cognitive features, and other psychiatric features, but it was really depressive symptoms. So having a symptomatic depressive disorder causes problems, not just in terms of emotional distress, but also in terms of your motor function and your ability to live independently. We also looked at cognitive instrumental activities of daily living and what factors predicted impairments in terms of your cognitive instrumental activities of daily living. And cognitive ideologies include include things like being able to use a telephone, manage your medications, and manage your finances. And over the 6-year follow-up interval, it was depressive symptoms as well as a measure of executive dysfunction involving set shifting, that was the TRAILS-B test, that predicted impairments along these lines. Cognitive disability was not associated with having a depressive disorder itself or with having motor deficits. So having depressive symptoms that are untreated and unrecognized affects many aspects of the ability of the patient to function at home, both cognitively as well as physically, as well as causing them to have a decreased quality of life. That's over a 6-year follow-up I've described, but in other studies they followed patients up to 15 years. And what we see here in the Sydney multi-center study, that's in Sydney, Australia, was that it wasn't the motor symptoms of Parkinson's disease that were most disabling over the long term. It was cognitive decline, dementia, hallucinations, and depression, all contributing to disability. And given that depression is treatable, it really underscores the importance of treating patients definitively for their depression. Well, what is the problem with why these psychiatric symptoms aren't recognized in clinical practice? And often that's really a problem of overlapping disturbances as well as overlapping clinical symptoms. And I'll describe those a little bit more. First of all, there do seem to be some barriers to recognition. And one of those is that the motor symptoms define the disease. Parkinson's is, the diagnosis is based on the presence of its classic motor symptoms. And often those are the primary focus of care and interest. And frequently these can actually mask the psychiatric changes. Similar to how I mentioned earlier when I spoke about the initial symptoms of the disease, slowness or aches and pains, etc. Often, though, however, depressive symptoms are regarded as an understandable reaction. I have Parkinson's, why shouldn't I be depressed, people will say. But that's really not the case. Also, depressive symptoms can occur with other mood disorders such as anxiety. There's also a problem with stigma. People don't often want to admit that they have depressive symptoms, thinking that it's perhaps a character weakness. In addition, clinicians are not always comfortable asking about depressive symptoms, feeling that the patient may be upset if they ask about these symptoms. And so what we get into is a situation of don't ask, don't tell, both with the clinician as well as on the patient's part. Often what you see as well is this problem of overlapping symptoms. And if you look at patients with major depression as well as Parkinson's disease, you see that many of their motor, cognitive, vegetative, and somatic symptoms are the same. And the one individual I think who can demonstrate that or illustrate that best is perhaps Eeyore. Eeyore is depressed when you think about the kinds of things he says. He's slow, but he's also slow-moving, what we might call bradykinesia in the case of Parkinson's disease, but in depression we call that psychomotor retardation. He is hunched over, he has a stooped posture, which many times a patient with depression will look that way. They have a restricted and sad affect, often not having much expression at all, or not making eye contact. And often we see this in Parkinson's disease, a patient with a hunched posture and this masked face, or the decreased facial expression, or what we call hypomimia. Agitation might also be looked at as a feature of tremor. When a patient with Parkinson's gets upset or is anxious, their tremor may be exacerbated. In both major depression as well as in Parkinson's disease, you can see problems with memory and problems with concentration. We see decreased energy, fatigue, sleep and appetite changes, physical complaints, sexual dysfunction, lack of sexual interest, stomach upset, constipation, muscle tension. All the features in Parkinson's disease itself you can also see in a patient with major depression. So it's not surprising that if you don't ask specifically about mood changes, that you might not detect that the patient has a persistent or unrecognized mood disorder. And what are we looking for when we ask about a depressive disorder? We really want to identify these distinguishing and persistent emotional features. And what you see with a patient who has a depressive disorder is a pervasive